Good afternoon. It's really my pleasure to be here today with this formidable set of speakers. I don't know about you, but I'm just finding this a little bit like intellectual candy today. So as we organized today and we reflected on the various themes of the paper that has really grounded our discussion, we knew it was going to be important to have a discussion about performance and quality improvement. And I think that we've heard this theme come through today through a variety of different talks. What I'm going to do is just take about 10 minutes. We'll see if I can pull off a 10-minute talk. Those that know me know that that's a challenge. But to really share some reflections on where we are as a health system, particularly in Ontario, and some of the current practices in place that support performance management and quality improvement. And I also am really just planning to kind of introduce the topic and ground it, because I think it'll be a theme that comes forward in our final panel as well. I'll also say from the outset that given my role in quality improvement, my remarks may have a heavier emphasis on this aspect, partially because of my natural bias, but also because we've learned over the last decade or so of instituting performance management systems in the province and elsewhere in the world that we can't simply expect to identify measures of performance, set targets, and hold organizations and the leaders of those organizations accountable to those targets. It doesn't actually work. And we actually need to make improvement in performance that really requires a very conscious, thoughtful, and concerted effort. And again, I think the study really sort of highlighted this point as well. It really does require establishing some foundations that will support and foster improvement, and a culture that makes it possible for teams and individuals to reflect and participate in improvement. So for the purpose of my talk today, I am going to ground it in a couple of concepts that I'm going to reference. So I'm going to take a minute to just define them from the perspective of what I'm speaking from today. The first is performance and performance measurement. And really, this will be used to describe the way we know how we're doing overall. It's data that provides us and or the public with information on a series of indicators of how we're doing, where variation may exist, and how we compare relative to benchmarks of performance of others by jurisdictions or peer groups. And a good example is in front of you here. Hopefully people recognize this. This is our Measuring Up report. It's our annual report to the public on the performance of the health system using the Common Quality Agenda indicators. The second term that is used is accountability. And in this context, it's going to represent a set of contractual commitments that organizations are required to deliver to. And in Ontario, probably the best example of this is the use of the LIN Accountability Agreement with organizations such as hospitals, CCACs, CHCs, long-term care homes. They really define the annual contractual expectations related to both a series of financial and program-related measures and targets. And this picture here, I actually just grabbed it right from the UHN website, and where every organization has their accountability agreement posted and available. And ultimately, organizational leaders are held accountable to what's in that agreement by their own boards. And then the third concept is quality improvement. And so quality improvement and quality improvement plans. So quality improvement here is really a systematic approach to making the change that lead to better patient outcomes, stronger system performance, and enhanced professional development. And critical to doing QI is that ability to reflect on data about current performance and identify both those areas of strengths and opportunities for improvement. And I think our last panel really demonstrated what we mean and what we're intending by that. And then a quality improvement plan itself will document that approach to improvement. And it acknowledges the need to be conscious about the aim, engaging teams in the identification of the change ideas, and to measure that change to determine the effect and include balancing measures that ensure that the change isn't resulting in other non-desirable effects. I think that's also a really important part of our conversation. The evidence is used to guide the interventions and that form the basis of making that change. And team members really feeling that sense of commitment and creating the change is critical. And again, I think we heard that this morning when we talked about how we were thinking about supporting patients with complex needs in new ways. creating the space for the innovation. So the example here is one from the Ottawa Hospital, used with permission to show the efforts that they have made to improve surgical site infection. By participating in the National Surgical Quality and Improvement Program, a program that enables hospitals to submit data and receive back comparative reports on a whole series of indicators, they identified that their overall outcomes from surgery were actually very good. But actually, their performance related to things like surgical site infection was much lower, the lower quartile. However, and importantly, there was a recognition that this was not a single individual's problem to solve, but rather required a systematic application of a bundle of change ideas that have been tested in other organizations to show improvement. So take that map and use it. And I really, when you hear the Ottawa team speak to that, it's really what they did. And it really requires several teams that include surgeons, anesthesiology, nurses, staff with skills, etc. And that organization committed to it in its quality improvement plan. And you can see that the result was, through that concerted effort over a 2-year period, they actually reduced their surgical site infection rate from 6% to over 6% to just over 1%. And I think now, this is just another example of one of these things that we're trying to introduce in Ontario, and we've got 35 hospitals that have joined NSQIP. They've actually come together as a collaborative, and actually they've committed to a common goal. So again, just to use it as an illustration. But when we think of these 3 terms and topics that I just described together, there's a way to design an approach that can be productive and complementary. Performance and understanding or reflecting on performance is clearly important for both purposes. Accountability approaches will establish certainly the base expectations. And quality improvement can serve 3 different purposes, actually. Early on, it can actually help us to just understand our data and determine its meaning. I like to term this as using it as a bit of a runway to understand where we are and where we might need to improve. It can help us to establish goals that will help us to meet our accountability requirements if we're not. And it can really actually inspire beyond that to excellence. And this is one of the themes in our QIP Insights to Quality Improvement reports this year, is people and organizations setting top box targets for their improvement. However, it's also not essential to link the QI and accountability from a more centralized perspective. I can say that there's many areas where organizations in Ontario are working on improvements based on what is really needed and is responding to local, responding to local needs. So, you know, where we are, sorry, I just lost my spot for a second. So, you know, where are we then overall in applying these concepts in Ontario? Well, when I look at the last 15 years in Ontario, there's been some substantial shifts. So early in 2000, we saw the introduction of the hospital report series. That started to provide public reports on the performance of hospitals. We started off with an anonymous, and then we actually started to identify who those hospitals were. With time, we saw the first accountability agreement actually introduced between the Ministry of the Hospitals, and Frank and I were actually working together back then at the JPPC with the first time that happened. In terms of quality and safety, we're all familiar with the landmark Canadian study by Baker and Norton that really raised the profile of the need to focus on quality and safety based on evidence that 7.5% of patients that were admitted experienced an adverse event. Then in about mid-2000s, given the richness of data available in the cancer system, more data became available about the cancer care and experience for patients. Methods to report that annually to the public on the performance of the cancer system were introduced, and there were new systems of accountability were introduced through regional cancer programs. There were variations in outcomes, like mortality rates for colorectal cancer, that were identified and actually very actively pursued quality improvement. And I partially wanted to raise that example because Robin was supposed to be here today, and she would have shared some of the experience in cancer, and I think it is actually an important one. It doesn't apply exactly to where we are today, but I think it's an important history that we've had in Ontario. And we've seen other disease-oriented agencies like the Stroke Network, Cardiac Care Network, really working on very similar things than what Tom spoke to this morning on our panel. And then over the same period, the LINs were created, and new forms of accountability agreements were established, and then a planning approach to services based on population needs was emphasized. So I think we really started seeing more emphasis on equity, more emphasis on mental health. So in 2010 then, Excellent Care for All Act comes, and it identifies, I think really started to galvanize the system around quality. It started with hospitals, it's expanded now to other sectors, and it defines what patients should expect from their care. It held us accountable to commit to a process of quality improvement. And I think that's really important. It actually held us accountable to commit to a process of quality improvement, reflecting regularly, identifying what those goals would be. Ensure that the plan included gathering information on both patient and staff experience, and that boards would hold leaders routinely accountable for the quality of care that they were providing. It created the organization that's HQO today to help support that, by providing an evidence base for us to support improvement, to report to the public, and actually work with the system to help to support improvement. So over the last several years now, it has been expanded to the community sector through CCACs, long-term care, and a portion of primary care. And this year as well, the changes to it have also included ensuring that patients are engaged in the development of those quality improvement plans. So that means now we've got 176 organizations that have formally identified, reflected, worked with teams, and identified their goals for the year. And they share them with HQO, and they share them with their communities, more importantly. And again, I think this really refers to the reform from the inside that Jean-Louis represented. Like the examples we heard in the last panel, that's what's going on in the 1,076 organizations across the province. So those that have heard me speak about this before, I think it's pretty amazing. I think it's really impressive, and I think that it's really important to stop and acknowledge just the phenomenal work and emphasis and quality that's being placed in the province. This slide, I think, the one thing I wasn't going to do today was to talk through any of the data on how we're doing. I actually think a lot of people are pretty familiar with it. We spend a lot of time talking about that. But the one thing we are familiar with as well is that the areas that we don't do as well in Ontario are those transitions. We've heard it referenced time and time again today. And one of the opportunities that we've got through something like the quality improvement plans is to design our priorities in ways that are going to complement each other. I was out with my friend last night who manages flow at one of the hospitals, and very quickly we started talking about the community. Very quickly, right? Like immediately, that's where we turned to. And this is really meant to be a bit of a platform that can help us to support those discussions. On the effectiveness indicators, which are in the middle, those are the ones that are really about practice. And I think that we still need to work at how we get them right. We've had some great successes. We heard about prescribing this morning in long-term care. This is an area that we too are seeing a major decline in Ontario, both by organizations working on it and practitioners accessing data about their own practice relative to others. But I think that, at the end of the day, we really need to think about what are our opportunities on a cross-sector basis to support this vertical integration that we've been talking about. And at the bottom, we highlight some new areas that we want to focus on to support improving palliative and end-of-life care. There's some good news, great news story as well here. This is just a snapshot of how hospitals are, some of the results that hospitals achieved over the last year. 131 met or exceeded their targets, 55 improved on 3+. We know what it takes, right, to move these measures. And that's pretty phenomenal. And you can look in here to see the work of those organizations and how they did it. In primary care, the same thing. This is looking at actually what primary care identified in all of these different priority areas. I will say the one difference between primary care and the hospitals is that they do select all the priority indicators to work on. And you can see that many achieved improvement and progress over the last year. And really importantly, we probably talked to more patients through surveys in primary care than we ever have done before. 70,000 patients responded to patient experience surveys to inform improvement. Going back to Andrew's talk from this morning on HealthLinks, we got the perspective of One Lynn and some of the HealthLink teams within that. This is actually now, we do have HealthLinks across Ontario. This data now showing for this quarter that 75 of the 82 HealthLinks are actively providing care to patients, identifying them, connecting them with primary care. And we're gradually seeing a very steady increase in the number of patients that are having coordinated care plans through this process. I'll also say in the quality improvement plan process that this is where people identify the collaborative efforts. So that exchange of data between hospitals, the CCACs and primary care, we're seeing that all around the province, and a lot of it is being enabled and being initiated partially because people want to support patients differently. This now just shows a little bit of information about how patients are being engaged in quality improvement activity. And I'm running out of time, so I won't spend too much time on this. But I think this is an area, going back to our last panel on co-design, that we'll only see increased involvement of patients. Finally, I think transparency is an important part of this. I didn't feel like we could finish this session without mentioning transparency and publicly reporting. So all of the quality improvement plans we've said are made publicly accessible as a bit of that public commitment, but also the ability for people to access them and share ideas. And on the left is just a small extraction from one of our mental health reports, where we really look at some of the differences that we see in where people are receiving care, and particularly related to some of the indicators of equity. So finally, it brings us back to this framework. And I think that, what we've heard today, that actually these enablers at the bottom are really fundamental and critical. That all the work that we've described here around quality improvement is only going to be possible if we can support providers to develop the capacity and knowledge to reflect on data, approach improvement. Programs like IDEAS and our physician leadership programs are really intended to help to support that. IT enablers are absolutely critical, and the use of order sets as one means of embedding evidence it needs to be part of our future strategy. That was also referenced this morning. But really importantly, I think we need to create the space to innovate, to foster the culture of improvement. And yesterday at the Choosing Wisely Canada meeting, I really think that also came through very strongly, that we need to really start small, think big, and pursue friendly competition where it's helpful and appropriate. And then finally, where we can create a community and opportunity to share ideas among each other, we really should. And I think that we've seen that today, that spread can happen when we create the right conditions. So my hope was to just set a bit of a context for performance, accountability, and quality improvement as it's happening in Ontario for this afternoon's discussion. But to end, I wanted to actually end with Pam's perspective. And Pam is a story whose story is shared right now on Faces of Healthcare, and she lives in a small community in Eastern Ontario. She's got a very rare immune disease that really leaves her highly vulnerable to infections, and in the last 36 months, she was in hospital for 217 days. And so she was actually identified as a good candidate for care through the Health Links. And really, they've looked at how they can provide additional services and supports in the home, actually help her with other things that don't necessarily relate to her health conditions, and in fact, it's made some dramatic improvements. And her quote is, "It's good to have an organization outside the hospital, sort of like the conductor, who helps to fill some of the little holes. I mean, there's so many people involved, but no one was bringing it all together. And in this case, the nurse practitioner plugged those holes. And now it feels like a complete system." And I think that that quote, I think, summarizes a lot of what we're trying to talk about today and what we're trying to achieve. So thanks very much.
We're actually, in terms of time, at the end of our session. But I think if there are one or two questions, I don't have any questions from those online. Are there any questions from those in the audience? Yes. Do you mind going to the mic?
So I appreciate both of your talks, and one of the things, and I'll put it on the table, I mean, I'm particularly sensitive right now from my role at the OMA and as the chair of the family doctor section, which basically represents a huge number of family doctors. And looking at accountability, right? And I'm kind of hearing with that lens on my head of not having an agreement with the government. But I was hearing a lot by way of accountability as if it was a contract of some sort, a formal contract, a formal agreement, a paper. I also heard a part about that we only have some family doctors and organizations that have this, and I think we have accountability agreements that are more than just papers. And the family doctors that I know struggle. Also, some of them are probably have some more work to do about what they're doing. But we have a different accountability agreement, which I think is our social compact. And I didn't hear that talked about today. So I think it's a really important part, and I respect both of where, and you had lots of things to talk about, but it's very disturbing where we have an inequity of resourcing distribution in our province, which we do. So we have a measure that could look at that, which is what is happening for the patients that do not have access to publicly funded allied health professionals in Ontario. That, to me, is a performance indicator that needs to be measured. It needs to be distributed. I'd send more up to Sarah because, oh my God, covering for 700 kilometers with 4 major practices is bleak, but wonderful, possibly, because you don't have to deal with a whole bunch of other people. However, that social compact piece, and when I talk to other professionals, I really hear it loudly, actually from my profession, which is family doctors, but I hear it from other doctors, and then I want to hear it more loudly from others, okay? Health policy people, government people, like, what is our social compact, right? And from patients who actually are getting there probably a lot sooner than the rest of us on, you know, when I'm running late, they say, it's okay, Dr. D, because, like, they know I'm not sitting with my feet up on my desk, you know? Like, you were taking care of somebody else. So we have a little microsystem in the office of where I am running late because somebody else was maybe needing more time or taking more. That's our practice social compact. So I'd like that to get incorporated a little bit more into our storytelling around this. I also really reject the idea that things come from contracts, okay? Because most of my day is spent without contracts anywhere. Like, our way to be, our way to interact isn't legalistic. It's not drawn from an agreement. That's not to say I don't believe in this culture of safety, culture improvement. Yeah. Absolutely, but most of it's not paperwork. It is about a commitment.
So thanks. I'm really glad you raised it because, to be honest, I had about 4 different sets of notes for this talk. And there was, you know, this sense of what accountability means, I think, is something that there's a lot of discussion about in the system right now. I chose for the purpose of today, and I chose it partially, too, because of the nature of the paper that we were basing today on. I deliberately chose to put it in that context of kind of contractual arrangement. And I was really trying to ensure that, again, from a quality and a quality improvement perspective, it can be because you have to do it, but it can be because actually you feel the need to do it. So I actually take your point, you know, really to heart. I think that healthcare providers generally feel a sense of accountability. It's actually why we go into healthcare. It's why we work in the health system. And so, you know, I just think I'm glad you've raised it, and I think it's a good point. And I made a definitional choice for today. Yeah.
I would agree, Lee, and I appreciate your having raised it. I think you're absolutely right that the social accountability experience for physicians applies not just in the practice context, but actually at that micro, meso, macro level as well, and there's lots of really fabulous family physician work being done to support resourcing for the whole of their population and sometimes the whole of communities. So I think your point is very well taken. Thank you.
Raisa, we'll give you the last question in this session.
Thank you. Yeah, I wanted to throw in a related nuance. There's a special issue of healthcare policy reporting a series of studies we did on approaches to accountability. Actually, Jean-Louis Denis was the sort of editor of it. And one of the things that we found is you have to be careful with accountability because people tend to go towards things that are easy to measure and that they control. And that what was found, and we repeated across the country and found the same thing, there is a real risk if you go too much towards formal accountability arrangements that you leave out extraordinarily important things that either are not controlled and are not easy to measure, in favor of things that are easy to measure but may not matter as much. It's a real issue in public health where you will drop out things like, are you going to be held accountable for how many people smoke in a poor community when you've got no control over it? So they drop all these things. And then you end up with a very distorted picture. And primary care is not particularly measurable. So it's just a caveat with all the talks we've been having of accountability that everything should be measurable. I think we've got to watch out for also what's important.
I can use the chance to make a comment, and where's Angie? I was talking to Angie earlier too about the work that's been happening in primary care around the Starfield model, which is also, sometimes we might actually measure stuff that may be at a granular level because we can, but actually to make it actually relevant and resonate to certain groups, we might actually need to come at that measurement differently. And I think some of the work that they've been doing related to Starfield is more of a composite measure that factors in relationship and some of these other things is actually a very interesting example of it.
It was one of our students looking at the transitions to care.
Yeah.
Totally wrong.
Right.
I think it's a really good point, and I think part of the conversation in the system now has to be around accountability for learning, accountability for goal setting, rather than accountability for punishment or the shame and blame, because those things that we want to hide don't help us move in any way. If we can set some goals and say, I'm going to be accountable for striving at this, and if I don't meet this benchmark, it's going to spur me to ask more questions, to look at what resources I need, to look at what other mechanisms need to be in place to support us to reach this goal. I think you're absolutely right. We need to have a conversation about what accountability means and what it means in different contexts. And I think I'll look at Darren Larson, who's been doing some great work around accountability and really engaging in the conversation. It's a really important conversation in the system now, and I think one that needs some clarity.